pediatric cataract is a big challenge. Though we all have basic requirements like general anesthesia, good setup of equipment or instruments, good biometry machine, efficient theater team, and your own expertise, but still decision making is very, very challenging in pediatric cataract surgery. Like the decisions making basically depends on age of the patient, the cataract, morphology, associated structural abnormalities, and laterality. And the decisions we have to make are on type of surgery, with or without PPC, with anterior vitrectomy, intraocular lens, now or later, or types of IOL, which one, bag or sulcus or iris fixated, scleral fixated, and target post-operative refractions, visual rehabilitation. So these are some of the things that we have to make decisions on in pediatric cataract surgery. And then the challenges increases when the cataracts are complex, like traumatic cataracts, inflammatory cataracts, subluxated cataracts, pre-existing posterior capsular defects, cataract with glaucoma, PFV, unilateral cataracts, microcornea, and there are many more. The list is more. So now I'll talk a little bit on how we manage some of the difficult cataract situations. Like in traumatic cataracts, it ranges from minor blunt trauma to a very complicated fibrotic cataract. So in blunt trauma, the cataract can be from sunflower to liquefied white cataract, synecdoche, angle recession, associated inflammations, thick fibrotic capsule, liquefied vitreous inflammation, old hemorrhages, retinal detachment. All these are associated with our traumatic cataract. And in penetrating or perforating, the things become even more complex, like it ranges from small peripheral corneal opacities to ruptured anterior and posterior capsule, thick fibrotic bands and retinal detachment. Any or all other layers of the eye may be involved. And surgery becomes difficult when the capsule is thick fibrotic adhesions, iris injuries, and lens trauma. So, and then again the challenge, the timing of the surgery, when to do the traumatic pediatric cataract surgery. So if there is a long wait, then chance of amblyopia. If the early surgery, then there is a chance of more inflammation. So wait for at least 6 weeks, suture remove, and at the time of the 6 weeks, what we can do is we can remove the suture, cataract extraction, and the IOL placement can be done in the same sitting, because in children, in almost every time, the general anesthesia always comes first. So that's why that is also poses a risk. And we can start with the short-term corticosteroid, oral corticosteroid is usually needed in traumatic cataracts. Long-term follow-up is required, and close follow-up for chance of glaucoma or other vitreoretinopathies. And another one is inflammatory cataract. The cataract and uveitis, careful anti-inflammatory, at least for 6 months free of inflammations, and endophthalmitis, wait for 6 months. Blunt trauma with inflammations, wait for at least 3 months under the cover of steroid, and post-operative medications is very, very should be carefully given. And like another complications associated cataract after the trauma is post-RD surgery, penetrating keratoplasty, trabeculotomy. So these are some of the important very challenging pediatric cataracts associated with other diseases. And then another challenge is the subluxated lens. If there is a large subluxations more than 180 degrees, then always lensectomy and anterior vitrectomy. And scleral fixation IOL should be done in older children only. And another option is the iris claw lenses, the glasses or contact lenses, and smaller subluxation CTR can be put with the intraocular lens. Then the microcornea. The cornea usually is not healthy, so chance of post-operative hazy cornea and corneal edema is always there in cases of microcornea. The IOL, smaller IOL, if available, can be given, and studies shows the good surgical outcome. No IOL in severe microcornea, and FEK glasses or contact lenses. And sometimes difficult to dilate pupils are also sometimes becomes a challenge, and intracameral adrenaline can be used in those cases. And pre-operative planning is very much important in cataracts. Complex cataract is always associated with ocular anomalies, so very important to identify those anomalies. Ultrasound, B-scan, and place for IOL placement, whether there is intact bag is present or not, sulcus is present or not, and that also makes the decision of which IOL to put. So I'll show some of the videos, short videos, in some managing complex pediatric cataract cases. This was the cataract with the trauma. So we come across all these difficult situations in our practice, and there was a big cataract with a big corneal scar and with a thick fibrotic membrane. And so cataract was removed, and then the IOL, the PMMA IOL was put in this case with a small scleral tunnel, and the lens was kept in sulcus. So whenever we have to put lens in the sulcus, for us there's few options. One is PMMA, the another one is 3-piece foldable IOLs, and the another one is the tetra lenses, that is one piece but still they have very good fixation. And there is another one, this is an inflammatory cataract. So this type of cataract also poses a big challenge, and the synecholysis was done, and then the cataract was removed with the bimanual vitrectomy cannula probe, and then so whenever, sometimes if the pupil is difficult to dilate, then the synecholysis can help a lot in doing that. And in this case, the foldable IOL was kept in the bag. The one-piece foldable IOL was kept in the bag, and then the vitrectomy was done after going through the limbal approach, going behind the lens. And then this is the cataract with a pre-existing posterior capsular defect. Sometimes we come across this, and in these situations we have to be very careful because there is always a large defect in the posterior capsule, so the cortical matter may go into the vitreous and the eye becomes very soft. So in these situations, the bimanual vitrector helps a lot, because the vitreous that comes along during the process can be easily taken out with the vitrectomy cutter that is always in your hand. And you can see there is a big already pre-existing defect. So I'm putting the tetra lens here in the sulcus. This is a very good and having a very good fixation in the sulcus. So I'm putting this sulcus fixated lens in this child, and then since it was already the pre-existing defect with the vitrectomy already done, so we don't need to do that again. And then another one is the membranous cataract, in which there is no anterior and posterior, the anterior posterior capsule is fused and there is no proper bag. But in this situation also, you can just use the vitrectomy cutter and then remove everything in a one go. So it's very easy. Then another one is, I just wanted to show sometimes in pediatric cataract, it becomes very difficult to dilate the pupil, and putting the pupillary stretcher is also very challenging. So I always try ask our anesthesia colleague for the adrenaline, diluted adrenaline, and then that saves me for all the complications. So putting iris hook and pupil stretch is also very challenging in smaller children, because you have to put sutures and all. And another one is the blunt trauma with the white cataract. This one was this again, there's white cataract, and we don't know the integrity of the posterior capsule. So in this situation also, it becomes challenging, and what is there inside you don't know. So though the B scan can give you some clue, but still whether the capsule is intact or not, whether there is fibrotic plaque or anything. So in this case, there was a thick fibrotic plaque on the posterior capsule after the removal of the lens matter. So I put the lens inside, the tetra lens again in this case, because the anterior and posterior capsule was fused and there was no proper bag, capsular bag. So I just put the lens in the sulcus, and then after that, behind the lens, I did the posterior capsulotomy and removing the plaque. And this was a very, very severe traumatic cataract. Sometimes we get these type of cases, so leaving them just is sometimes we can do at least to try something to make that visual axis clear. So at least if the posterior part is intact, posterior segment is good, then the child can have some amount of vision. So in this situation, in this type of situation also, we can at least clear the visual axis, and sometimes the intraocular seizures has to be used in these situations. Only the cutter cannot open the thick fibrotic capsule. So this is another very severe traumatic cataract case with a thick corneal scar, and then with the use of cutter and scissor, we could at least clear the visual axis in this case. And we can always prescribe the phakic corrections. So these are some of the cases, and complicated cataract always pose a big challenge, and management requires a holistic approach with all the subspecialty involved, and bimanual vitrectomy in these situations is a very wonderful tool. And but at the same time, we have to give a good parental and patient counseling, because pediatric cataract is not a one hit and go thing. It has to be a long-term follow-up, and rehabilitation is involved, and timing of surgery and implantations depends on individual cases and surgeon's clinical judgment. Thank you so much for the